Hello, everybody. Greetings from HCFI Foundation of India. I'm Dr. K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. And you are having an interaction in the weekly meeting of Roundtable. This is 47th meeting of Roundtable. And for me, it is 1739th meeting. And today we are discussing on possibilities why number of cases are increasing in Mumbai and in Kerala. Will this mean that the second wave will come in India, or will this wave die out in Maharashtra of its own? I'll give a short 10 to 15 minutes presentation and followed by a discussion in this particular thing. So when I want to give a short presentation on the subject, so what are the three basic reasons when you have surge in cases? So whenever there is a surge in cases like we are having in Mumbai, what are the reasons for surge in cases? The first is a mutation. So without a mutation, surge will not come. There are 2 mutations per month occurring in this virus. So therefore, we expect 2 surges every month in this particular condition, but that's not happening. Now, it will depend upon the type of mutation. Is it a deletion or substitution? Is it in the RBM or not? And because of this mutation, is there a change in the behavior of the virus? Has it reduced its doubling time, or is it increased its infectivity period? That will divide about the possibility of that mutation surviving. In association with that, it will depend upon COVID inappropriate behavior of the society. So there should be a mutation. There should be a COVID inappropriate behavior surge. That means suddenly there has to be something like a political party or opening up of a college, opening up of schools, something has to be happen. And then there has to be a super spreading event preceded by a super spreader. So 3 things have to be there to cause a number of surges in. Let's take the example of Bombay. We will come back to the discussion. There is a mutation. There is a COVID inappropriate behavior surge because people started moving in the local trains, and there were super spreading events because the whole families were getting infected. So whenever you find the whole spurts in a particular family, you know this is a super spreading event. So will this Bombay mutation come in Delhi and other areas? Let's discuss. So let's discuss one by one. What is a deletion or substitution mutation? What is a deletion or substitution mutation? There are 2 types of mutation, deletion and substitution. Now, what do they mean? Let's take the virus in the bottom. In the spike protein, there are 1,255 amino acids. One amino acid gets deleted, that's permanent. The amino acid is dead. The dead person cannot come back. So therefore, deletion type of mutations are permanent. Therefore, 6970 deletion, which originated in cluster 5 in Denmark, now present in the virus in the UK, is a permanent deletion. And then Y144 deletion is also a permanent deletion. So the virus in the UK has 3 deletions. That means out of 1,255 amino acids, 3 amino acids have been discarded. This becomes a permanent deletion. So now we have to say this permanent deletion has to be associated with a behavior change. 6970 is causing S gene target failure. And for behavior change, it requires a mutation in RBD or RBM. And therefore, it comes out in 501 mutation. So 501 mutation gave it 501 mutation, which is present in RBD, gives it a behavioral change. Then it also has a 681 mutation, which is at the fusion protein. So therefore, UK variant is going to take over the whole world because of fusion plus RBD plus 3 deletions. Why South Africa and Brazil mutations are dying down? Because if you see the number of cases in South Africa and Brazil, they have started reducing. And that mutation has not established itself in other parts of the world because it does not have a deletion. Though it has 3 mutations in RBD and RBM, but it has no single important deletion. Therefore, these 2 strains may not be important to South Africa and Brazil. Both are showing cases are going down. In UK, one of the patient has acquired one of the mutation of South Africa. In addition, that is E484K new mutation has come. So therefore, it becomes important. Now in India, we are seeing 2 types of mutations in Bombay. One is 440 mutation. Second is 484 mutation. 484 is the same mutation which is present in South Africa and in Brazil, and now has been seen in the UK variant. And 440 mutation, both the mutations are RBM. Therefore, we in India are getting isolated substitution deletions, which will cause a spurt and it will die out. So my assumption is that Kerala strain and Maharashtra strain may cause a spurt in Maharashtra, may not cause a spurt in the neighboring country, neighboring states or other countries, because these are temporary substitution type of mutations which will occur and which will go. That's what I presume with that. The second thing which comes is that why the UK strain is persisting. UK strain, if you compare the 2 together, this is a study published in Harvard, which says that in the UK strain, the clearance time of the virus is 12 days and not 8 days. And the mean acute infection duration is 20 days and not 12 days. That means the virus in the UK, the virus present in the UK is showing reduced viral load, but it is persisting for a longer period of time, and it has an infectiousness for a longer period of time. That's the reason it will spread in the community, but it is less lethal because the virus load is low. Though one study has shown that it is also more virulent, but virus load is low, that's for sure. That's what this graph shows, the UK versus non-UK virus. And then we come back to the another thing which coming is, what does this mutation wants? Virus wants to persist forever. It will like to become chronic. So in UK strain, it has lasted for 14 days. But what about this patient? What about this patient where there is a patient who showed that the virus was reactivated after 4 months? In one of the patients published in Nature, they have shown the virus got reactivated after 4 months. That means in this particular patient, the virus was alive for 4 months in the body, which is for the first time we are talking about this phenomena. And in such cases, if the virus is delayed and present in the body, we can have delayed onset myocarditis. We can have. So the topic today is, the discussion today is, what can be the reason of this virus increasing in Maharashtra and in Kerala. In Kerala, we will listen to Dr. Jayakrishna. But two strains have been told that in Maharashtra, new strains have come. One of them is 484. Second of them is 440. Both of them are isolated mutations, that too in the RBD and RBM portion of the spike protein. But will this spread throughout the country? Doesn't look like. These will be like, we have 3 waves in Delhi. Similarly, we may end up into 2 or 3 waves in Maharashtra. It may not be a variant of a national concern because this is an isolated mutation, not a multiple gene mutation, and it is not associated with multiple deletions. Over for discussions. Dr. Jayakrishna. Dr. Anita Chakravarti. Anita, madam.
Can you hear me?
Yes.
Can you hear me?
Yes, madam.
Yes, yes, we can.
Yeah, what I think is, number one, these mutations or what is happening, actually the virus, what I understand, has come from outside. So I don't know if there's any history of travel of any person who's come to this particular pocket in Maharashtra and they have the history of travel from outside. If so, they might have transmitted the virus. Now, if there is not any major deletions, and if there is just minor modification in the proofreading capacity, then the virus may not cause much of a harm and it will be located only to that small little region. But if there is a new virus, more mutations, what I understand, there isn't so much of a mutation. So it should not, it would be self-located. And second thing is that the body is now taking some time in producing specific immune responses. So, so if the body can produce the immune responses to the modified virus, then it can take care of it. That's my assumption. Because even the variations which are seen in the other countries, initially they don't come under control, but they ultimately, the attack rate comes down. It could be prolonged. The problem is if a virus is prolonging in the body for a longer time, the body is enough, the virus has, enough capability to fight the immune response of the individual and then change its, properties. So its capabilities of causing infection. So that is the major problem, and it causes a slow infection. That was also seen in China for some time in those people who were having gastrointestinal tract infections and all that these were the viruses which stayed for a very long time and they were detrimental. So that's what I think. That's my assumption.
So you agree that this virus may not be a matter of serious concern to the country. A, does not have deletions. B, does not have multiple substitutions. And 484 and 440 have been responsible for local spurts in many countries as a spontaneous mutations.
That is what I would assume. That is what I would feel.
I know,
and I would like to feel.
That's what is happening in other countries also, because people are only concerned about the UK virus more than the South African and Brazil virus in South African and Brazil. And UK virus has more mutations which are susceptible to the virus, which are liked by the virus. Dr. Jayakrishan, can you tell us about the...
KK, just 1 minute before Jayakrishan comes in, I was just talking to our HPI Maharashtra president, and he was telling me that in Bombay, definitely over the last 1 week, the number of hospitalizations have increased significantly. Just for your information.
Yes, that's a new wave. See, we are saying there is a new wave in Maharashtra. There is a new wave in Vidarbha. We have identified, the government have identified 2 new mutations. So there is a new mutation. There is a mask inappropriate behavior, and there is a super spreading event. So what we are talking about it, will that become a national crisis or not? That's the issue of discussion.
Okay.
We are not denying that. So we say there is a new wave in Maharashtra. Will that wave create an impact in the whole India? Will that wave be converted into a national wave? So we are only discussing it because if the new mutations which they have said does not contain deletions. That's an isolated mutations, and there is a inappropriate behavior. There is a spreading event. So therefore, this virus may not cause a national concern. That's the discussion. So this may, as we have seen, that UK virus in UK versus virus in South Africa and virus in Brazil, the South Africa and Brazil virus has not caused a concern outside South Africa or outside Brazil. By this time, it would have become a pandemic of the South African variant, which hasn't happened, probably because these were standalone mutations, which will die out and recorrect by the proofreading mechanism. So but this is what Dr. Anita is also saying is that a virus mutations are going to come. Virus has a proofreading mechanism. Virus can autocorrect substitutions. Virus can autocorrect substitutions, but virus will not autocorrect deletions. So unless you have significant deletions of an amino acid, which makes viral more infectious or virulent, that virus will not come into. So if you see from MERS and SARS on COVID-19, there are 98 deletions. So from MERS virus to become a COVID-19 virus, 92 amino acids were deleted from the genome. So therefore, what we are trying to say is, as long as, why UK is because there are 3 deletions. So anything which has a virus beneficial deletion, the virus may not become a matter of international concern. That's what we are talking about. Jackson.
One thing I wanted to say, if I can come in, is that no virus has been studied so much till date. We have the tools and everyone, and this is a virus which has affected the whole of the world. Ebola virus, poor country, therefore vaccine was not available to so many. Is down with the virus. So what is happening is, like it's almost like nitpicking, every angle is being assessed. Today I read somewhere 7,000 ke upar there are mutations. Many viruses have mutations, but no one has gone into these tiny finicky details. Agreed, major mutations, major deletions, yes, that might lead to something. But when this virus has a straight genome, it is unlike the influenza genome. How much it is going to affect, I would still be, not that, it has to be seen. That's all.
Dr. Jackson?
Yes, sir. It's very important that there should be more discussion on the resistant strains. And this discussion will throw light on the behavior of the resistant strains. Another intriguing factor is that in Kerala, my state, although there were a lot of control measures and lot of health activity, the COVID cases are still in a plateau phase and it's not decreasing. And as such, the UK strain, South African strains, everything is very less and very well quarantined and controlled. So that behavior of the disease Kerala is still quite intriguing. And I would just like you to comment on that also.
I agree with you that the number of cases are static. But if I want to show you the cases, let me come back to the Kerala. See, in Kerala, we have seen two mutations which are increasing, and that is C1240Y mutation and P84T mutation. And if you see this mutation on the bottom, P84T is in the N-terminal domain, but it is far behind RBD. And then C1240Y is almost in the terminal part of the yellow portion in the virus, in the spike protein. So both these two mutations can increase the spurt of cases for some time, but they cannot become a mutation of importance that it will start spreading all over. That's the reason in Kerala, it is now dying out. It has reached a plateau, and this number of cases will die out. I don't think so at present in Kerala, we are having a concern because these two mutations which are known in Kerala are for a long term, they will be insignificant.
Sir, can be a active vaccination, early active vaccination among all sections of people will be a more effective method than the present stage-wise vaccination.
Yes, absolutely. One of the reason is now what people are suggesting is that you pick up one or two states. Like for example, if you want to kill Maharashtra and Kerala, you take two states and intensively vaccinate them and stop the progression of a disease. That's happening in many countries. Instead of focusing on 20% of the population, they are picking up 100% of the population getting vaccinated in areas of concern.
Dr. Agrawal, I got a question.
Yes.
In Maharashtra, what I realized, I just want to check with you, is it because of the mutation of the virus which is increasing the incidence, or it is the carelessness of the people? Because when I see in Bombay, it's absolutely careless. People are not following any regulations. Hotels are full, halls are full, cinema theaters, everything is just like a normal thing with total disrespect to the protection which is to be used for corona.
Therefore, I'm saying single factor will not work. There have to be a combination of three factors.
Yes.
The first factor is there has to be a new mutation. Number two, there has to be a spurt in cases of inappropriate behavior.
Yes.
And third, there has to be a super spreader in the society. One person who gets it, who is a super spreader, inappropriate behavior, he catches the infections to multiple people at the same time.
Yes.
It cannot be all three of them, because if you see inappropriate behavior, you are finding in Delhi also.
Yes.
Okay, so inappropriate behavior is pan-India, not only in Mumbai. But the combination of three, which is causing this particular infection. The wave will only come. So in India, if you see all the waves, they came with these three combinations. They were inappropriate behavior. Suddenly, आपने गाड़ियां चालू कर दी. Suddenly, migration हुआ. But alone, that will not cause. So we have identified. So we say there are 2 or 3 mutations in Maharashtra. Then there is an inappropriate COVID behavior by the people, and 1 or 2 super spreading events occur.
Yes. Yes. Thank you. Thank you.
Otherwise, the infection will not rise so much.
I think that was my concern. You must attend to each one independently.
All of them, yes. Because if this mutation becomes multiple mutations, like 23 mutations occurred in UK. Therefore, it became a virus of concern, which will replace the whole world.
Yes.
Ultimately, UK virus will replace the whole world because it has 23 mutations with multiple deletions. In Maharashtra, what we are noting is a substitution, Maharashtra, Kerala. So any mutation which is a substitution mutation will autocorrect and it will die out. So therefore, I am not anticipating a national wave.
National, yes.
I am anticipating a state-wise. In Delhi, we had 3 waves. When Delhi was having a third wave, wave was absent elsewhere. So you can have a state-wise waves occurring. So therefore, what I have been able to study is 3 reasons for a wave. Single reason will not work.
Yes.
Single reason. And another most important thing is that if you like a UK variant, if any of the, because nobody is doing a study in India, how long the infectivity lasts of a new mutation. Normally, we are presuming the virus is dead on 8th day, which may not happen. Suppose you say the new variant in Maharashtra has changed its behavior. Now it is alive for more than 14 days. Then the spread will not discontinue. Spread will continue.
Yes. Thank you, KK. Thank you.
Sir, now ICMR has yesterday clarified that both Covaxin and Covishield is effective against all mutant variants. But South Africa has stopped Oxford vaccine and switched over to Pfizer. So what's the reason ICMR has told that, and why South Africa has stopped Oxford vaccine and switched over to Pfizer, even both are working against spike proteins?
So number one is there is no data by India to show that Covishield and Covaxin are working against the strain in the South Africa and Brazil. These are relative statements. These are relative statements. Relative statements are that serious disease will not occur. So these are relative statements. Now South Africa has not returned the Covishield. South Africa has not opted for a Covishield, and they have given, because they had a commitment of certain vaccines to be given to other South African countries. And therefore, they are saying we will go for the Johnson & Johnson, and this vaccine we will give it to other neighbor countries. So I don't think so there is an issue there. It has been made as an issue. It is like you have 2 options. You have 2 vaccines coming and you say, one vaccine I'll use it for myself and one vaccine I'll give it to my neighboring countries to whom I am committed to. So I don't think so there is any issue into that. Definitely Johnson & Johnson vaccine has shown to be more effective than Covishield. Okay, so for example, if India would have allowed Pfizer to come into India, 20% of the population would have opted for Pfizer, not for Covishield. That doesn't mean Covishield is bad. Now, South Africa says we have 2 options, Johnson & Johnson, which is a single dose vaccine. So we will opt for that. That's okay. That doesn't mean that the vaccine is bad. Definitely the efficacy of the vaccines to a newer strains will always be lower. So I got my second vaccination was due yesterday, but I will go on Monday and take it. My first dose has not produced any antibodies. So I'm going ahead with I'm not postponing my second dose. I'm taking my second dose on Monday.
Dr. KK, why you said the first dose has not developed, you have not developed any antibodies after first dose? Are we not expected to have some antibodies generated after first dose?
You were supposed to get, say my wife got 47 antibodies.
Yes.
All my family has developed antibodies. I haven't. I may be a vaccine failure or my antibodies are delayed or I may not form antibodies at all. So there are, because that's what efficacy is. say 5% after Moderna says my 90% efficacy means in 5% antibodies will not form.
So you can be on the other side of the efficacy.
Yes, I can be a vaccine failure also.
Vaccine failure.
But it depends upon the vaccine given or my body. So therefore, I'm not delaying my vaccination. I'm going for a second vaccine dose.
So will it amount to your first dose? Basically, if you are not developed antibodies in the first dose, the second dose to be considered as the first dose?
No.
Second dose.
No. I'm not in favor of the third dose.
Okay.
I'm not in the favor of the third dose. I would like to ask Madam Anita Chakravarti. Anita ji, what are these antibodies which are disease-enhancing antibodies? Can you explain the mechanism of a disease-enhancing antibodies?
Disease-enhancing antibodies are usually produced by T cells, which are giving rise to a lot of cytokine productions. And they are also the neutralizing antibodies, which are produced in very low amounts. So what happens is that because they are produced in low amounts, they don't actually neutralize disease. But then you have a lot of cells coming which produce the cytokines, and usually it's more of the anti-inflammatory cytokines which come into play. So when a large amount of pro and anti-inflammatory come, then you get the cytokine storming.
No,
so that is the reason of ADE.
I'm not talking about initial cytokine storm. I'm talking about a person who develops corrupt antibodies. I call them as corrupt antibodies, which are disease-enhancing antibodies. And when a person gets reinfection after a month, then that infection gets facilitated by the antibodies instead of getting reacted. Something like a multi-system inflammatory syndrome. So what are these corrupt antibodies? What are the mechanism of these antibodies which facilitate a virus entry and do not kill it?
They are not only IgG antibodies. You see, the mechanism is very complicated. You have a whole lot of things coming into play. You have complement pathway also coming into play. And there are the T cells also which come into play in a big way, you know. The killer cells will not come into play to that extent. So all these things come into play. It's not a simple B cell which is producing immunoglobulins.
Why I'm asking this question is,
see what happened here.
What I'm trying to say is,
I'll just say,
will repeated vaccine, but third
Sorry?
dose of vaccine, will the third dose of vaccine harm or help? That's what my question is.
No, this is going to cause harm. Na? AD is going to cause a harm. Because normally post-vaccination, we have IgG antibodies being produced of certain types. I think it's usually IgG 1 and 3. We have 4 IgG types. So most probably in this, you have IgG 1 and IgG 3, if I'm not wrong. So the antibodies, even which are protective, are different types of antibodies in the immunoglobulin class. So here, it's not a simple mechanism. Lots of things come into play when they cause disease enhancement.
So therefore, why I'm asking this question is, say for example, I have got a COVID-19 in the past. So I've got one natural infection, one natural vaccine. Now I'm taking my first vaccine, which will behave in my body like a second dose of vaccine, which now chance is coming that one should not take the second dose of the vaccine if I have suffered from the natural infection. So what is the harm of taking multiple vaccines? Will they precipitate disease enhancement?
In the case of COVID, this is my view, it should not produce disease enhancement. Because if you have already got the disease, it is asymptomatic. Otherwise, also you're going to take 2 vaccines. Because I didn't know that I had the disease. But many times in a young person whose immune response is good, he may be asymptomatic, he may be producing antibodies. He doesn't know about it, and to give both the dosage. So that would be his third. So he is producing. In fact, in hepatitis B, something like this happens when you have those escape mutants. So you have a certain percentage who don't who don't react to vaccines, they don't respond to vaccines. So there are some write-ups in which they say that you have to give another dose, maybe it will help. But those are all maybe. Some say yes, some say no. So yes, second, third can be given. As per me, yes. If you are having infection and then you are getting 2 doses, there are so many who are asymptomatic. And so many of them are getting vaccinated with 2 doses now. In fact, there has to be some studies. People should be doing all these studies. I mean, agency should be doing these studies before they vaccinate. First dose ke baad, second dose ke baad. Then only we'll come into. Probably it's being done. We'll come to know within a month or 2.
Okay, Anita ji, can I come in here? Just a
Yeah.
question, keeping Dr. Agrawal's example in mind. He said after first dose there was no antibodies developed. How long should we wait for antibodies detection before the second dose? And in case of a total failure of like 90% efficacy, is it safe to go for number 2 and number 3 doses, and what interval should be there in terms of protection? I mean, comparing my case also with KK, I done my IgG, which is 110 now. And there's no history of infection to me, but somehow my IgG is 110. So, but if there is a failure of first dose, what are the safety precautions for second and third dose?
One thing is a lot depends on what vaccine you have taken. Number 2 is just a minute. I'll go to the other room. I'm at work. So the second thing is that the first dose usually does not produce that much of protection. So you may not get that high rise of antibodies. It is known and it has been documented. And the third dose is the one which gives you the antibodies. And it's very clear in so many publications that the second dose, after 2 weeks only you should see for the antibody titer. So first dose, I don't think you need to be so afraid. Perhaps after the second dose, you should be getting it. I am a little concerned about I'm really concerned about it. I've been talking to lots of people. I mean, couldn't we have the second dose of vaccination after 12 weeks? Where everywhere it is, even yesterday's Lancet article is telling you that the 12 weeks is an ideal period and you get better immune response. So yeah, our government's policy is different. But I was just feeling it would have been such a good idea to give lots of people the first dose. And then 12 weeks afterwards, you give the second dose, especially for people of our age group, in which our immune responses may not be that well developed. Because this is an age group. Even I had the vaccine and I realized I did not get any side effects. That means, in all probabilities, I have not developed a very good immune response. I have not tested myself. So this was in my mind, and I would really tell Dr. Agarwal to get the policymakers and let them debate on this. That would be really nice. The policymakers, the ones who are really telling about the vaccination, whosoever they are. Because after the first dose, if you cover more people, more coverage, so some transmission would be less, and you have the second dose after 10 to 12 weeks. The article was published. It came out in February 2019, and it's in Lancet. It's an excellent article. So I would really request Dr. Agarwal to, if you could have a panel discussion with the policymakers who in India are making the policies.
Ansaji, one more point which I picked up from your conversation. If the post-vaccine reaction is poor, it means our immune response is also poor, and we are not likely to develop that quantity of antibodies which a younger person, a younger age group people are doing it. So is that an indication of a likely to be poor response of the vaccine if we don't have a post-vaccine reaction?
Post-vaccine reaction means your cytokines are coming to play. And that means that your cells are more active, but you can't assume. You cannot. Immunology is not that easy. One cannot assume.
Yes.
But I know by age, this much we can say that as you get older, your immune response to everything becomes less. You're always, you succumb to things much more than youngsters. And you all as clinicians must be knowing it when you treat the patients. So the body immunity plays a very important role.
Thank you. Thank you, Anjali.
Say, I can only tell about myself. I did not have any feeling, any pain, nothing. And my antibodies have not been formed. Because my antibodies are not being formed, being a high risk person, I am taking my vaccine on Monday. That's my conscious decision. But yes, government should come out with an option, because at this moment they are not giving an option. If they give an option, people themselves will delay their second dose. See, if government gives an option, even if they don't mandate it, then all healthcare workers will shift their vaccine to 3 months. But the question comes here is government is not ready for the list with the whom to give a injection. If doctors refuse after 3 weeks, they are not ready. They are not having an alternative plan whom to give. So I don't think so government will change its policy. But scientifically, yes, it makes sense. So I am telling all my doctors to get your antibodies done. If your antibodies are absent, go ahead with vaccination. At least out of 100 people, I have seen only 2 people like me who haven't got the antibodies. Everybody has developed the antibodies. If you check, everybody has developed the antibodies. So let's see what happens with that.
You have developed the antibodies, but the amount of antibodies is less. Definitely there are antibodies.
How do we know unless we check it up?
Yeah, no, but there is a cutoff point in which the antibodies would be, more protective. So maybe the amount of antibody is less.
Maybe we'll check it up with the second dose. So I got 2 testing done. Both of them I tested. Both the testings I got it done for my S antibodies, and one Diason one. Both are from Diason, which is S1, S2 antibodies, and both of them are negative. So I didn't go for the neutralizing antibody test. So I will take out my sample, one more sample before I go for the vaccination as the third sample to see, and then get it done again after 2 weeks. See, what is happening is government is not taking the medical profession into confidence. It's the policymakers who are deciding, and they are not taking the medical profession into confidence, where there can be an open forum where they can answer their queries, but that's not happening. We are, say, these types of decisions that Mumbai, they have not come out with a transparent statement so far. So people live in fear. With that, people live in fear. And that fear creates a problem. Government should be transparent. Government should say that we are also learning. What's wrong in that? If they make a statement and the statement comes out to be wrong, so what? Because it's a new virus. So today we have
That is true. That is true. I only wish it was more flexible. But could the IMA do something about it? I mean, I don't know.
So Jai Kishan will be able to tell. They are in the IMA now.
My suggestion is that government should go in for a walk-in policy for vaccine. There should not be prior registration. Anybody with Aadhaar card or ID card should be registered immediately and provided first dose of vaccine. If there is any issue with payment, those below BPL can be given free of cost by government, and those who are above APL can be have some payment to be given to the government. So actually, there should be a walk-in policy other than this prior registration, which is producing a lot of hurdles around.
See, unfortunately, IMA and the government, at least for the last 7 years, I am saying, they are sitting across fighting each other. So therefore, neither the government will listen to IMA nor IMA will listen to the government. Somehow or other, on some protest or the other, for the last 7 years, both of them are fighting with each other. Current IMA also is fighting on a particular issue. The issues may go on changing, but the fight continues. In that particular scenario, the government takes an advantage of deciding what they want to. I am not been able to understand. I've been in that seat for 3 years, and I've never been able to realize this government policy of creating something which agitates IMA, and then that issue continues for 4 or 5 years, and the issue dies out. NMC problem lasted for 5 years. The agitation lasted for 5 years. PNDT Act, the Nursing Home Registration Act, and now Ayurvedic doctors treating. The issues will go on for 2 years, 3 years, 4 years. And during that period, important time is lost where they can have cohesively work in the interest of the society. So for one particular issue, 99% of the issues are not discussed or not cared for. That's the way I look at it. Yes, Alex.
Yeah, no, I think what Jay Krishna and what you have said is very true. I think they need to get the professionals involved, because sometimes the decisions are so illogical. So just want to say that HPI has written to them. We're very persistent. So I think when was it, yesterday or day before, we had sent a proposal saying that we spoke to all our state presidents, and they're willing to start massive. I think all of us have to agree that our rate of, if you compare to other countries, our vaccination rate is very, very low. I think less than 1% compared to Israel, 80%, etc. So we have told the government this, and we said that our hospitals are ready to do this. And I think we have negotiated with the vaccine guys. They initially said 500. Now they said they'll give it at 300. And we told the government, if you add another 100 rupees, maybe 50 rupees for the nurse, it won't cover the cost for hospitals, but hospitals all over the country are willing to do it. So I hope these are for people who are willing to pay. We said, do not compromise on the poorer society, that you continue. But this is additional.
Is the company ready to sell?
Government has to give them permission, but they're more or less okay with the rates.
Do they have the vaccines?
Yeah, I think actually in many states, many of the vaccines are now reaching expiry date. So we lose a lot of vaccines if you're not alert. So let's hope that.
I'm talking different things. I'm talking. What I'm talking to is.
Yeah, the
capacity of Covishield is 8 crores a year to make. Out of which 4 crore they have to give it to COVAX. So only 4 crore vaccines are available in India. Do they have the capacity to manufacture and make it 8 crore? That's the issue. Or 16 crores or 22 crores.
Yeah, they have the capacity to increase. So, but unless the government gives them the green signal, this won't happen. So we are trying various.
See, if Covishield wants to raise money, like a telephone, they can raise the money today by advance money. You pay your advance, you will get vaccine in priority. So therefore, generation of money can never be a problem for a venture like this. They can move to the Supreme Court. If you give me the data, I can move to the Supreme Court. But then we need a data, because we have been told that they have no capacity to manufacture.
No, they have.
No,
anyway, I'll get back to you on that. But I think the issue, KK, is that as you said, the government has to listen to us.
That is agreed. Therefore, we are saying we are looking for points so that we can move to the court and discuss out with the government. So what I'm trying to say is, as on today, government said they wanted 35 crore to be vaccinated in 6 months. That means 6 crore per month. They have only done 1 crore in 1 month.
Yes.
Okay. With this 1 crore per month, they will take 35 months. That means 3 years to cover 35 crore, which can never be approved.
Yeah, I agree. So actually, KK, our Tamil Nadu branch is approaching the Madurai High Court to the PIL, saying that we should be allowed to start vaccination. So I'll ask him to get in touch with you.
That's what I'm trying to say is the government says, okay, allowed. But where are the vaccines? That's what I'm asking.
I think, see, from the little knowledge I have, there definitely is potential to increase the rate of vaccination. Definitely at least double or 3 times because the vaccine is available.
Can anybody stop IMA or AHPI to approach the Poonawalla and have his name is, and have a meeting with them?
I think at the moment, yes, because at the moment it's regulated. No, even whatever they're
No,
exporting.
talking regulated? Is talking regulated?
No. I think we can discuss with him, and I think.
If he says, if they say that we have the capacity to build up the vaccine, then there can be a real movement in the country to force the government to build up a production.
Okay. No, I think we had some informal discussion. So I'll get back to you on that, and maybe we need to also look at the legal approach.
Okay. Yes, Ashokji.
I want to bring to your notice that there are several people, those who are posting their pictures who are non-healthcare workers, front workers, on the social media that they got vaccinated. So if the vaccine is primarily to be distributed only a recognized center for front care healthcare worker, how these social groups, I know some people in the Agrawal group and other group, they are posting how they are getting access to the vaccine. Is it legally or through the illegal means?
This is our country.
No. Say, if you are practicing, then all your workers in your practice are to be given the vaccine if you register them.
Yes.
Suppose if you are practicing, so you will have 4 people in your house, you are helping in your clinic, they are frontline workers. These are the people who are getting vaccinations. That's allowed. That's how government is saying any doctor can bring in their staff, register, and they will be given the vaccine. The vaccine is not for doctors. It is doctors and their clinic staff.
No, agreed. Even for my staff, I had to register to this BMC list. But these people are no way connected with the doctor or healthcare, and despite that, they are sharing. So, is there any?
These are the people who will say, I am the PR agent of Dr. Ashok Gupta, or I am the.
No, that is okay. There's still some amount of siphoning of the vaccine going to the.
It's not siphoning. It is doctors obliging people as a part of their staff.
Okay, it's good. Yes.
It has to come through the doctor. They cannot siphon off. Okay. So some of the doctors, say for example, you can have a lawyer, you can have a PR consultant, you can have a person who is visiting you, helping you in your profession, you can have your accountant. Those can be covered.
Yes.
So this will continue. This will always be there. These are the opportunities given to healthcare staff. Okay.
Yes. Thank you.
So, if, Anshika, you want to share something?
Sir, I can ask a question on the same discussion that is happening. And given the number of cases that are rising in Bombay, is it advisable for government to tender to supply the vaccine to neighboring countries? Because apparently we are doing great right now, but eventually
50% of the vaccine India is committed to donate it to other countries through COVAX thing. That's a different issue. I don't want to go into political debates. As on today, we only know is that government has vaccines are getting wasted. There are no takers within the community. So everywhere there is difficulty going on. But I don't want to go into the debate of the government decisions in a live program. So if there are no other talk, then I will request Dr. Ashok Gupta to sum up today's discussions. Anil, you want to add something? Then Dr. Ashok Gupta can sum up the meeting.
Sorry, KK, I joined a little late, but I will start with the point Dr. KK Agrawal raised, that there is a spurt in number of cases in Maharashtra and Kerala. Maharashtra being in the front line, and their point of discussion for Maharashtra is, one is a mutation, second is a inappropriate behavior of the people, and third was the other factors also, which include the poor vaccination, poor healthcare protection, etc. And then based on the discussion with Dr. KK showed also the type of mutation which can take place, the incidence of mutation which is happening in different part of India, including Kerala, Maharashtra, and he shared the chart showing different state where the mutation can mutant variants are present. Then there was a discussion came on the quality of mutation which is happening in United Kingdom and South Africa and Brazil, and how the some mutation can have a cumulative effect and some mutation will have died down by themselves. So this has to be done on a long-term basis with proper precaution. Third question came when Dr. K.K. Agarwal shared his own example when he said after first dose of the vaccination, there's no antibodies developed in him, and he's ready to go for a second dose, which is on coming Monday. And then the whole lot of discussion was initiated by questioning Dr. K.K. Agarwal's report, which I initiated. What is the reason for not getting the antibodies? And he shared that this could be a poor immune response, or it could be a negative side. All these vaccine companies are making 90 to 95% efficacy. So maybe Dr. K.K. Agarwal and people like him are falling on the other side of 95%, and they are not getting the antibodies developed by that. Dr. Anita Chakravarti was requested to explain this behavior, and she explained in a very technical way with all the specification and clarification of different methodology of antibodies development. But in conclusion, it came that in the age group and age factor which most of us are in, there could be a poor immune response per se in most of the conditions, and the level of antibodies should not be related or connected to the efficacy of vaccine. It could be some delay, it could be some sort of a abrupt or concealed antibodies, and then second dose will definitely be beneficial and will boost the immunity. Then the question came, if we consider the first dose as a negative or a zero dose, is there a need for another 2 doses? And Dr. K.K. Agarwal very blatantly said he is not willing for a third dose. And that raised the question, which dose should be considered as the most potent or a immune booster dose? The 0 dose, number 1 dose, or number 2 dose? In case if there is no response in 0, that should be considered 0, then the first and second dose. And that's still a question of debate. And Dr. Anita referred to an article which was published in Lancet, and I also had gone through that article, which clearly defines that the gap between the first and second dose for a most ideal response should be minimum 3 weeks or 4 weeks or even up to 12 weeks time. And that is the ideal recommendation which should be sent to the Ministry of Health and the Government of India by our group, that there should be a minimum gap of, longer gap up to 12 weeks is ideal for getting the boost response, immune response. And then there were some questions raised about the vaccine wastage, export of vaccine, misuse of vaccine, which I also shared the incidents where people are posting on the social media, they think they got the vaccination done, although they are not connected anyway with the frontline healthcare workers. And again, this is India, and it can happen in India. People are taking advantage of their goodwill with the doctors and healthcare workers and getting it done. Then the question also was discussed about the expiry date and the production capacity of the vaccine companies. Are they capable of fulfilling their requirement, or are they willing to enhance their capability and capacity for vaccine production? So all these factors have really stirred the hornet's nest, I would say, in the current scenario of vaccine and vaccination and the manufacturers. How to prevent misuse. I was also wondering, I was to argue whether there's an element of placebo in the 100, number of vaccine given. Say out of 100, 1 or 2 could be placebo, or 5 what there's a negative, which also needs to be analyzed by a select group. What is the percentage of placebo vaccine and what is the percentage of actual vaccine which is being given? Because this is still part of the study by the manufacturers. So I think with all these factors, a lot of discussion took place, and we again coming back to the final conclusion that even after vaccine, you cannot stop your appropriate behavior of the COVID, and you must follow all the precautions which are necessary to prevent spread of COVID. And we must identify the super spreader which could be the most dangerous element in rise in the number of rise of cases of COVID across the states. And what Dr. KK assured most of us, that the Maharashtra and Kerala episode is less likely to become a national pandemic, because it is limited to only small pockets of the different states. So that's a very assuring conclusion of this today's roundtable discussion. And once again, thanks Dr. KK for elaborating so many important points to us.
Thank you everybody for joining this movement. We'll be back next week. Namaskar.
Thank you.
Thank you. Namaskar.
Thank you.